Our next speaker will be Matt Adams, who will be discussing assessing risk of stapedectomy in patients with otosclerosis and semicircular canal dehiscence.
I'm back here to present a study that I did with Dr. Sperling and a few other collaborators at Northwell. This study is entitled Assessing Risk of Stapedectomy in Patients with Otosclerosis and Semicircular Canal Dehiscence. So some background, as we know, otosclerosis occurs due to dysregulated bone remodeling at the otocapsule, often resulting in a progressive conductive hearing loss. There are certain conditions, such as superior canal dehiscence, which are considered by some stapes surgeons to be a relative contraindication to undergoing surgery. There are very few reports in the literature up to date that kind of describe these patients that have both otosclerosis and superior canal dehiscence. And so, why is this potentially a contraindication? So this is the idea of the immobile third window. And so if otosclerosis and superior canal dehiscence are concomitant, patients have an immobile third window at the location of the oval window, and then performing stapes surgery could potentially unmask these symptoms of worsened hearing, vestibular symptoms, as well as dysfunction, and as well as autophony. And so the majority of the literature that's been published thus far that cautions against stapes surgery in these patients is really retrospective in nature in their logic. And so these patients have had a failed surgery. They then undergo CT imaging, which then leads to the discovery of radiographic superior canal dehiscence. And so there's really been a reporting bias in the literature and a potential overestimation of risk. And many of their conclusions might overlook other potential causes of failure. And so this kind of generates our question of if radiographic superior canal dehiscence is identified preoperatively, can stapes surgery be performed with good hearing outcomes? And so this was our primary objective. Our secondary objective was also to identify any factors that might assist the stapes surgeon in the management of these patients with concomitant otosclerosis and superior canal dehiscence. So we performed a case series with chart review. These patients were of Dr. Sperling's during his time at Northwell Health. All patients were seen at a tertiary care center. He had 270 otosclerosis patients in his database, and out of those, 18 cases were identified having concomitant otosclerosis and superior canal dehiscence. Our main outcomes for the study were to look at the pre- and post-operative pure tone averages, air bone gaps, as well as the approximate dehiscence area of the dehiscence. And so I'll describe that a little bit more. And so there's a study recently published in the White Journal by Yang et al. They described the approximate dehiscence area. And you can see in the figure that I included from their paper, what they essentially do is they count the number of sequential images in both the axial and coronal views, where they're showing the dehiscence. They take that number of slices and multiply it by the slice thickness of the scan. And they do that, like I said, for both the axial and coronal views to get a length and width. And then they multiply those two values together to generate an approximate dehiscence area. Okay, so talking about our results. So just to kind of show our distribution of patients, like I said, we started off with 270 otosclerosis patients. 18 of those were identified to have concomitant otosclerosis and superior canal dehiscence. 8 of those patients underwent primary laser stapedectomy with Dr. Sperling. 2 underwent revision surgery. 6 were advised against surgery due to a series of clinical data. And then 2 patients were referred to him after having surgery with an outside surgeon and presented with a poor surgical outcome. Okay, so first table here, so just presenting the demographics and radiographic data for the primary and revision stapedectomy patients. So the age range here was between 38 to 74. There were 4 males and 6 females. Like I said before, 8 were in the primary group, and then there were 2 that were revision stapes surgery groups. All of the patients except for 1 had a negative RINA test. 1 had a positive in the revision group. And then, some studies have looked at acoustic reflex and Carhart notch as an indicator of, is this Otosclerosis versus superior canal dehiscence, really driving the patient's pathology, and use those as clinical indicators. But as you can see, we had there was variability between some that were some had present Garhart notch, some did not, acoustic reflex present and not, so on and so forth. Now looking more at the audiometric data for the primary and revision stapedectomy patients, all but one primary stapedectomy patient had closure of the airborne gap to less than 20 decibels, and then all but two had closure to less than 10 decibels. The mean improvement of the air conduction pure tone average and airborne gaps were 26.1 and 21.1 respectively, which were significant, but neither revision stapedectomy patient had closure of their airborne gap. No patients reported any unmasking of third window symptoms after surgery. Here are the demographics and audiometric data for the patients that were advised against surgery. After review with a neuroradiologist, actually only 2 of those patients were found to have radiographic otosclerosis, and all were found to have bilateral superior semicircular canal dehiscence. 3 patients were found to have reported third window symptoms when they were presented to Dr. Sperling. Interestingly, all of the patients that underwent CVEMP prior to surgery were found to have a present, but most of them were all decreased thresholds, excuse me, on CVEMP. And finally, here we look at the approximate dehiscence areas across all of those 4 subgroups, which you can see listed here. The operated patients, which we included both primary and revision groups, they had an average approximate dehiscence area of 2.57 square millimeters, while the group advised against surgery had an ADA of 3.73, and this difference was not statistically significant, excuse me. All patients had involvement of the dome of the superior canal, and then 2 patients, patients 11 and 12, which both had larger dehiscences, they also had involvement of the anterolateral upswing of the canal as well. And then we stratified these patients based on the presence or absence of a CVEMP threshold. And so this idea is that an absent CVEMP threshold would be an expected outcome in a patient with otosclerosis, whereas a present threshold would be considered an unexpected outcome in a patient with otosclerosis. And so we broke up those 2 groups, and then we looked at the ADA between these 2 groups. So there was a mean ADA of 1.24 for patients with an absent threshold, and then those that had a present threshold had a mean of 3.39. And this difference was also not statistically significant. Okay, so this is the largest case series to date. I know it is very small, but these cases are fairly rare. Patients that have identified both concomitant otosclerosis and superior canal dehiscence. And this is the first study to really report that patients can have a good hearing outcome after surgery. And so our main discussion point here is that surgery can be done successfully in patients with both otosclerosis and superior canal dehiscence without unmasking third window symptoms. There is, however, a possible increased likelihood that there could be partial closure of the airborne gap after surgery. Revision stapedectomy patients, similar story. They also did not have unmasking of their third window symptoms. However, they did not have quite as good of an outcome as this group had an improvement of their pure tone averages, but neither did have closure of their airborne gaps. We did not find a difference in the approximate dehiscence areas between the operated and unoperated groups, but I really feel that this is likely an underpowered issue here for the study. And future directions would be to further investigate the relationship between a present and absent CVEMP threshold with the approximate dehiscence area. And so this idea that can a present threshold, or is there a certain cutoff of a threshold which can somehow predict a poor stapes surgery outcome in patients with radiographic superior canal dehiscence. And so for this, we would need a larger sample size. Some of the limitations of the study. Overall, it's a fairly uncommon condition, like I mentioned earlier. The study just has here we reported just about a little over 5% incidence out of Dr. Sperling's patients specifically. The study is retrospective in nature and comes with those limitations, of course. And this is a single surgeon study. Dr. Sperling has a very high volume otosclerosis and stapes surgery practice. there's also a limitation to the technology. And so this idea that are these patients that have very small dehiscences, do they actually have a dehiscence, or is this a limitation of the CT scan technology that we have? Is the slice thickness too large? And so there are emerging techniques such as photon counting detectors that might improve diagnostic accuracy and help further tease this out. Are these patients truly having dehiscence, or is it just a very, very thin eggshell of bone over the superior canal? Here are my references, and any questions?
No, come on. No questions?
Yeah.
Dr. Sperling and I have talked about this, and he's presented this stuff at New York Otologic on several occasions. But the thing about superior canal dehiscence is that we get a lot of patients referred to us now because radiologists see them and they send them to me, and they have no symptoms. And the vast majority of people that have a superior canal dehiscence have no symptoms of it. And it's one of those things that's kind of a mystery. There are people that will have half their canal gone, but no symptoms. And it has to do less with that than something else. There's something else that's going on. And so I tend to agree with Dr. Sperling that if you have somebody that you can see otosclerosis on the scan, they have an absent reflex, then you should probably think about doing a stapedectomy on them, seeing if you get your hearing better. And if they don't get better, then start looking for it. But it has changed the paradigm for the evaluation of otosclerosis and stapedectomy, because before this, we were thinking, what's the bother of getting a CT scan? If you got a hearing test that shows a Carhart notch and all that, and part of the operation is to confirm the diagnosis before you do the stapedectomy, the actual stapedectomy. See the otosclerosis, make certain the footplate is fixed before you do anything. And it's a visual diagnosis, but we're almost all getting CT scans on these patients now.
I think another important point, and you touched on it as a limitation, but I actually kind of think of it as a strength, is this was a single surgeon who does a high volume of stapes surgery, so you'd expect excellent outcomes given the experience there.
And by the way, Dr. Sperling has done CT scans on all of his patients for a long time, because he feels you can see the otosclerosis, and he likes to be able to see it.
Yeah, we were limited by, his database goes back pretty far, but obviously we couldn't use patients from his time at Cornell or time here and things like that, so.
You should have put it on an Excel.
Well, yeah.